Okay, so thank you very much, and I'm thrilled to be here today. And I sometimes do wonder, how did I ever get from being a radiographer who actually didn't go to university at 18, because radiography, you didn't go to university in those days, to being the chief executive of a community and mental health services trust here in Cambridgeshire. And if anybody is ever interested, I'll share the journey. But I just think that actually, for me, certainly, that just typifies all of the opportunities that the NHS is able to present to people over the life course. And actually, that's what CPFT does over people's life course. What I want to say follows on perfectly from, I think, Steve's challenge, actually, about what is in the long-term plan. And I'd like to talk about why I think, actually, there's lots of good stuff in the long-term plan. And I agree with Roland, the second half of it is exciting, because there is lots that isn't defined in terms of the specifics of what or how. But the challenge is there presented to leaders like me, like Roland, like many of you, to create that future. So let me tell you about CPFT, Cambridgeshire and Peterborough Foundation Trust, because you just might know nothing about us. So we're an integrated physical and mental health NHS Foundation Trust. We're very active in research, and I really think that we punch above our weight in terms of research. We're a trust with turnover of about 220 million a year. We're CQC rated as good. We're in the top 5 mental health research active organisations in the country. We employ nearly 4,000 staff. They work across the county, across Cambridgeshire and Peterborough, in over 50 locations. We look after just short of 1 million people in terms of our population, and our purpose is to improve their health. Our purpose is that simple. It's to improve their health whilst also looking after the health of our staff. We're only as good as our staff are well, motivated, curious, innovative, but ultimately healthy and coming to work to do a good job every day for that 1 million people. And I'm really proud that actually I think they do that well. So physical health, mental health, increasingly working in absolute partnership, a partnership that I really hope in a couple of years' time we will not be able to get a fag packet between our staff within CPFT and our partners in primary care. And I think the long-term plan is absolutely right, that integrating around a restructured primary care, looking after a population, it not being about who employs you, but actually the passion that drives and motivates everybody is working with that population to create the best care for that population. Virtually everybody has a computer in their pocket. We really need to embrace how we use that intuitive, easy technology. My mother is nearly 80. She's got an Apple Watch, she's got an iPhone, she's got an iPad and a laptop. She's on Twitter, she's on Facebook. She does more than I do, and she's nearly 80. So it's a myth that old people can't access this stuff. That kind of technology can transform dementia care. It can really enable people to continue to live independently in a supported way in their homes. You see babies in prams, I'm not sure I like it, but you see babies in prams with pink or blue iPads, actually. If it's easy enough for somebody who's not quite yet walking and talking, then it's great for people who've got cognitive impairment. So some stats there about what we do and how we do it. You can read it for yourself. I won't bore you by reading all my slides. But what I really want to do is to talk through why I want to stand here and say CPFT is open for business. One of the things that I've learned in the last 18 months in CPFT, and it is something that surprised me, is that partners in industry find it really hard to break into the NHS, and I'm not sure that I can be naive, because I'm not sure why that should be. Actually, people working in industry and working in science are seeking to find solutions to the very same problems that we're facing every day. Increasing numbers of people with multi-morbidity, frailty, wanting to live independently in their homes, but often living on their own, sometimes in great big houses, sometimes actually in really poor accommodation. We all, I think, want to help those people to have a better life. So why do we struggle to join up? Why do we struggle to innovate? So I'm going to kind of put my hand up and say CPFT is open for business, and if you struggle to access us and if you want to work with us, then find me. That's the best way in, is to text me, email me, Twitter me, whichever you want to do. I forgot to put the contacts on the last slide, or I could say Malcolm took them out, but that wouldn't be true. But actually, you know, there are easy ways in, because actually we're up for it. So why are we up for it? So our laboratory doesn't have test tubes. Our laboratory is the high street. We also host the Clark, I hope soon to be the ARC, Applied Research Collaborative. We've got populations in focus within that, who over the next 5 years, we want to translate research into practice through our ARC, join our ARCs up across the country to make adoption and spread of practice technology change that does transform people's lives. And I really believe that we can do it. And I think an organisation like CPFT probably isn't the first thing you think about in terms of innovation and science. We don't have test tubes, we don't have lots of scientists with gloves and pipettes and fancy things, but we do have lots of clinicians out and about every day with their agile technology, talking to people in the population, in the future working much more intimately with primary care and making a difference to people's lives. We also believe that physical health and mental health are not the separate entities that people have believed for the last 300-400 years. And it's really obvious, because we're all people who have a mind and a body and who live in an environment. And I think our joint work with hospitals like Adam Brooks, through the Department of Psychiatry within the University of Cambridge, we're really bringing the science of body and mind together. But what CPFT can bring as a partnership is taking that out into people's homes where they live and across the population. I don't like us having 50 locations, actually. I probably like us having however many houses there are within our population of 1 million people. We have that many locations because that's where we work. So a little bit here about co-production. We are an organisation that innovates, and the thing I love about working in CPFT is I have the privilege of working with some people who are really clever, but also really smart. And there is a difference between those two things. But actually, people who are both clever, smart, wise, and actually really good fun to get on with, that is just an enormous privilege. Out of that, we've developed things like the first response service for mental health. We have 24/7 access to mental health through 111 option 2. We're the only part of the country that offers that, but it's in the long-term plan to be rolled out across the country. PRISM probably means nothing to you. It's mental health within primary care. So we've got mental health practitioners who work within every GP practice, over 100 GP practices in Cambridgeshire. We developed that because we didn't have enough money to carry on providing mental health services the way that we have done traditionally. So our clinical staff solve problems through trying different things, doing different things. And I think my job is just to open up the doors and enable them to do that in ways that are obviously safe, but actually in ways that embrace that curiosity and creativity that they just have tons of. But what we recognise is we can't do that on our own. So some stats and figures here about our research. We do have some commercial research, but I would really like to grow that. Most of our research and application is within mental health. Actually, physical healthcare in the community is 55% of our business now. Nobody is really doing weighty research and application within communities and physical healthcare that I know of at scale. We would love to do that. So a little bit about our innovations again here and some of the opportunities. We've got some great people who work again with us and the university, joint appointments, who they've got brains the size of I just can't keep up with, but actually really competent at drilling out data, doing analytics, and really joining up data that enables us to know what works, but also what doesn't work and what should we stop doing. So we've got some really, really smart people who would love to work with partners in industry and with the data we get from our population to start to explore what works, what could we do more of, but actually what should we stop doing? How should we shift the way in which we're spending the resource that we've got? We also, I think, can translate into practice in the field, and I've possibly said enough about that already, but with our Applied Research Collaborative, it's not just about the pure science, and particularly the brain and mind science. It's also about the kind of science that changes people's lives on a daily basis. So we really want to explore how we can use technology to shift people's lives and their outcomes in ways that work for them as much as for you and as much as for us. So why do we want to do this? So I'll come back to that one in a minute. So I think the reason that we want to do this, and I'm going to bring this back to the long-term plan. If we carry on providing healthcare the way that we do now, if we carry on recruiting staff and training staff the way that we do now, we'll need to build another 77 large hospitals to accommodate the acute illness in this country in 10 years' time. We can't afford to do that. We also couldn't recruit and train that volume of staff in that time scale in order to fill those hospitals with staff. But we also know that our population doesn't want to be that sick, actually. People want to be in hospital when they really need to be in hospital, but if they really don't, they'd much rather be at home with their families. So the thing that I think is absolutely right in the long-term plan is the focus on prevention, that in the NHS in my 35 years, I've never yet seen us get round to do that properly. We have to do that prevention using technology, using new science, but doing that with people in their homes, in their workplaces, in their schools, in their colleges. So actually it's self-care, self-prevention, and I think populations are up for that now. I also think that we need different models of our workforce, different career structures, and I think that we do need to equip people to have those digital skills, that digital capability that Charlie talked about. We need to use that data and analysis and that learning to continuously know that what we're doing is making a difference for our population, and if it's not making the right difference, that we use rapid data to try something different in a safe way and know that we start to build much more continuous improvement. So I'm going to bring this back to CPFT. So what's the ask from us to you in industry, and what's our offer? So the ask is that we share concepts, products, developments that we can test and grow together. The ask is that we work together, and I think John and Malcolm described the way this works with Philips in a way that really resonates. That we work together on a formal, legal, but simple and humane basis. But that we share goals, we share aims. That's where successful partnerships come about. What we want to do, the things that I've had here, this is the ask: improve the health of our population. But I want to do that in a way that improves the health of the population in Cambridge and Peterborough, but that's applicable nationally and globally. These challenges are not just here in the UK. Tech that makes it easier for staff to do a great job. That's why they come to work every day and do the jobs that they do. Innovation adoption at scale. If we were a supermarket and somebody found a way of getting the trolley back to the bay that you get your trolley from, and one supermarket found it, they'd all have done it within 3 months. Why does it take us 17 years to take something that's proven and good and get it in place across the whole country? We've got to learn from industry how to do this quicker and better. And we want to create new knowledge that does have this global impact. And I think one of the things in CPFT is we look after people over their life course, cradle to grave, in their communities, providing services for children, younger adults, but also older adults, and some of the most vulnerable in our society who need a lot of support and care right through their life. But our offer is that we also therefore have data along that longitudinal life course. It's no way perfect, but working with you, we can make that very much better. I think we have got these people who are academic global leaders within our organisation and within our partners. I think that we also want to move quickly. It's a 10-year plan. We don't have 10 years to deliver the 10-year plan. We need to start making many of these changes now and start testing and trialling these ways and building the energy and the enthusiasm now. We do want to publish. We'd like to do that jointly. We do want to publish so that we can share and so that we spread. And I think that ultimately in CPFT, I think we're confident in our ability to embrace and adopt and design new models of care delivery. And I feel that the track record we've got from the stuff we've generated internally, we know how to do that safely. And I think doing it safely is really important, particularly when we know that we need to do things quickly. So I'm just going to stop there. Malcolm, I hope I've not been too fast or too slow or gone on for too long. I hope you like my tag tree that I created. I think we're growing green shoots, but the hands demonstrate, I think, the care that we need to put in place underneath that, but actually the partnerships that we need to form in order to grow. Thank you.
Thanks, Tracy. The observant in the room, which is all of you, will have noticed we're running a little late. Good news. It won't take me 15 minutes to sum up. It'll take me a lot less than that, so don't panic, as they say in Hitchhiker's Guide to the Galaxy. But because time is pressing, is there a burning question from the floor? I'll take that as a no. We have some on Slido. Can we... I'm just trying to look at and just check out for any that are likely to come up in the subsequent conversation. Let's take the middle one. So, Tracy, do you think industry have been scared off by the cost of trying to develop something which can bridge both physical and mental health care?
No, I don't, actually. And I don't know why it would cost more to develop something that bridges the two. I think what we get wrong, and if you speak to one of our professors, Ed Bullmore, or read his book, it goes back about 300-400 years, is we think of physical and mental health as very separate things. But actually, those of us who are lucky enough to have children, we look after our whole child. We don't look after the child's mind and the child's body. So, no, I don't think industry's been scared off by the cost. I think that we scare industry off, because I don't think industry thinks that actually the NHS is up for integrating physical and mental health, actually, because we're structured and have been forever along parallel lines. But actually, the people we look after, nobody with a long-term condition, and particularly people who have many multi-morbid long-term conditions, I think we do well to find somebody with that degree of poor health who has not got a mental health component to that illness. Actually, it must have a psychological impact.
Is it a quick one, Peter? Cubs on her? Yeah.
I really loved your presentation, actually, but I've got to confess, halfway through the presentation, my phone vibrated, and the world I live in, my dad's got Parkinson's, but I got a notification on my phone that my dad's forgotten to take his drug. I looked to quickly look on it. He's at home. As you say, your own mother using iPads and all that type of stuff. Same with my dad in Parkinson's.
Yeah.
But the dilemma I've got, or the issue I've got, is I've got a company in Germany who's developed a Parkinson's monitor that fits on their waistband. It's a 3-person company. They've got all the research papers to show it's brilliant. But when they look at over this side of the country, where'd they go with it?
They could come to me. We've got a Parkinson's team working out in the community. They could come to me, and we could do that here.
I shall forward. Thank you. That's the right answer. Perfect.
There's a reason why I didn't put those contacts up, isn't there? But really seriously, we have a specialist neuro community nursing team who look after people with severe Parkinson's. The fact that you, as a relative, are getting messages to say he hasn't taken his meds, that our community, our district nurses currently, they've got all the agile tech and everything, but they are still spending their time going from patient to patient to patient to patient. At least they don't go to base to patient, back to base to base to patient. It's better. But actually, Band 6, Band 7 community nurses, I see them in future spending some time out in patients' home, but spending more time looking at what the tech is telling them, advising less experienced staff about what that means for the people who they do see, but liaising with patients through the technology rather than spending a third of their time in their car. Much more time, clinical value added, but in ways like that enable patients to self-care safely.
Thank you. I'll send you an email.
A comprehensive answer to your question. Thanks very much, Tracy.